So systemic disease have been implicated as risk factors or indicators in periodontal disease, and some of those that are implicated include nutritional influences, endocrine disorders, hematological disorders, immunodeficiency disorders, cardiovascular disease, other systemic disease, psychosomatic disorders. These disorders affect the periodontal tissues and modify the disease expression. Nutritional influences. The research on nutritional influences on the periodontal tissue has led to the following conclusion. Nutritional deficiencies produce changes in the oral cavity. There are no nutritional deficiencies that by themselves produce gingivitis and periodontal pockets. What are fat-soluble vitamins? They are vitamin A, D, E. Vitamin A deficiency results in hyperkeratosis, hyperplasia of the gingival epithelium, proliferation of the junctional epithelium, retardation of gingival wound healing. This is the diagrammatic representation of vitamin A deficiency, where you can see hyperkeratosis. Vitamin D deficiency results in osteoporosis of the alveolar bone. Osteoid forms at a normal rate but remains uncalcified. Reduction in the width of the periodontal ligament space. Cemental calcification, defective and cemental resorption. Alveolar bone changes include resorption, proliferation of fibroblast replacing the bone marrow. Radiographic changes include complete disappearance of the lamina dura, reduced density of the supporting bone, loss of trabeculae, increased prominence of the remaining interstitious, and increased prominence of the remaining trabeculae. The vitamin D deficiency, where you can see a kind of a bow legs in case of rickets. Vitamin D promotes the body's absorption of calcium, and it is essential for the development of bones and vitamin E deficiency. Vitamin E serves as an antioxidant. The cell membranes high in polyunsaturated fatty acids are sites of action of vitamin D, and vitamin E increases gingival wound healing. This is vitamin E. What are the benefits of vitamin E? Vitamin E protects the cell membranes and tissues from damage by oxidation. It aids in the formation of red blood cells, and the use of vitamin K promotes the function of healthy circulatory system. We move on to the water-soluble vitamins, which are vitamin B complex, vitamin C. The B complex includes thiamine, riboflavin, niacin, pyridoxine, biotin, folic acid, and cobalamin. The deficiency of vitamin B causes gingivitis, glossodynia, angular cheilitis, inflammation of the entire oral mucosa. This is the diagrammatic representation of patients with angular cheilitis and glossitis. This is vitamin B1 deficiency. Thiamine deficiency causes hypersensitivity of the oral mucosa, vesicles on the buccal mucosa, under the tongue, palate, and erosion of the mucosa. Riboflavin deficiency causes glossitis, a magenta colored tongue with angular cheilitis, dermatitis, superficial vascularizing keratitis. This riboflavin deficiency characterized by corneal vascularization, dermatitis, glossitis, angular cheilitis, and anemia. Niacin deficiency is called as pellagra. It is characterized by 3 Ds: dermatitis, dementia, and diarrhea. Glossitis, stomatitis, necrotizing ulcerative gingivitis usually is seen in areas of local irritation. Folic acid deficiency causes macrocytic anemia, where there is necrosis of the gingiva, periodontal ligament, alveolar bone without inflammation. The absence of inflammation is because of granulocytopenia. There is generalized stomatitis and glossitis. This folic acid deficiency. Vitamin C deficiency is scurvy. It affects infants in first year, old adults, and alcoholics. The clinical manifestations are hemorrhagic lesions into the muscles of the extremities, joints, nail beds, increased susceptibility to infection, impaired wound healing, bleeding gums, swollen gingiva, loosened teeth. In scurvy, there is a defective formation of collagen, retardation of osteoid formation, impaired osteoblastic function, and increased capillary permeability, susceptibility to traumatic hemorrhages, and sluggishness of the blood flow. This is the picture depicting vitamin C deficiency. What is the etiological relationship between ascorbic acid deficiency and periodontal disease? It is given by Wolf et al. In 1980. Metabolism of collagen is affected in the periodontal ligament, and the collagen fibers are the last affected. Bone formation is affected, increased osteoclastic resorption is present, increased permeability of the oral mucosa to endotoxins and the clavicular epithelium to dextrin, increased levels of vitamin C enhance migratory action, chemotactic action of leukocytes. Vitamin C helps in maintaining the integrity of periodontal microvasculature, and vitamin C deficiency alters the bacterial type and favors more pathogenic phenotype. So it produces gingivitis and periodontitis. Gingivitis is not caused by vitamin C deficiency but by the dental plaque. Vitamin C deficiency patients do not per se develop gingivitis. Periodontitis, you can see edema, hemorrhage into the periodontal ligament, osteoporosis of the alveolar bone, tooth mobility, collagen degeneration in gingival connective tissue. Protein deficiency, what are the periodontal changes we see? There is degeneration of the gingival connective tissue, periodontal ligament, osteoporosis of the alveolar bone, and retardation of osteoporosis, reduction of osteoblast. Starvation, there is total lack of nutrients. So we move on to the endocrine disorders, which is diabetes and hormonal fluctuations associated with puberty, pregnancy and menopause. Diabetes is a complex metabolic disease characterized by chronic hyperglycemia and altered lipid and protein metabolism. Uncontrolled diabetes is associated with macrovascular disease, increased susceptibility to infections and poor wound healing. The different types of diabetes are type 1, type 2, gestational diabetes, and diabetes secondary to syndromes like acromegaly, Cushing syndrome, pancreatic tumors, and drugs. The oral manifestations are angular cheilitis, mucosal drying, burning mouth and tongue, high amount of Candida albicans, hemolytic streptococcus, and increased chance of dental caries is present. On the periodontium, you have gingival proliferations is seen, which is polypoid, abscess formation, periodontitis, loosened teeth. Periodontitis in type 1 diabetes starts at the age of 12. Deep pockets, rapid bone loss, and multiple abscesses present. More periodontal destructions in long-term diabetics is seen. The risk of developing periodontitis is threefold more in type 2 diabetes. Gingival clavicular fluid of diabetes has greater glucose levels. Qualitative changes in subgingival bacteria are seen. Type 1 diabetes with periodontitis is associated with the following subgingival flora: Capnocytophaga, anaerobic vibrios, Porphyromonas gingivalis, and Prevotella intermedia, and AA, that is Actinobacillus actinomycetum comitans. Polymorphonuclear neutrophil function is impaired, chemotaxis, adherence, phagocytosis is altered, and there is alteration in the immunoglobulin levels. There is altered collagen metabolism, there is increased collagenase activity, decreased collagen production, glycogen depletion in gingiva, generalized osteoporosis, alveolar bone resorption. AGE to collagen is less soluble. Hyperparathyroidism is a condition where there is increased parathyroid hormone production, there is generalized demineralization of the skeleton, proliferation of the connective tissue into the resorption areas, and formation of bone cyst. This is called as von Recklinghausen's disease. This is a hyperparathyroidism. There is skull decalcification, there is parathyroid adenoma, osteitis fibrosa cystica, nephrocalcinosis or kidney stones are present, renal infections or renal failure can occur, epulis, which is a giant cell tumor, metastatic calcification of the lungs, peptic ulcer, pancreatitis, and muscular atrophy is seen. The oral changes are malocclusion, tooth mobility, widening of the periodontal ligament space, absence of lamina dura, radiolucent cyst-like spaces. The bone cysts become filled with hemosiderin-laden macrophages, that is giant cells, that is called as Brown's tumor. Loss of lamina dura and giant cell tumors are the late signs of hyperparathyroidism. This is the picture of Brown's tumor, where you can see hemosiderin deposition. Sex hormones. Variations induce non-specific inflammatory changes with a predominant vascular component leading clinically to marked hemorrhagic tendency. Progesterone will cause vasodilation, increasing the permeability of the gingival microvasculature. Estrogen causes endosteal bone formation, decreased polymerization of mucopolysaccharides. Testosterone retards the downgrowth of cellular epithelium, increases the osteoblastic activity, and increases the cellularity of periodontal ligament. Puberty gingival changes, the exaggerated response of gingiva to local irritation. Pronounced inflammation, pronounced inflammation, bluish red discoloration, edema to presence of local factors. In menstrual cycle, you can see bleeding gums, bloated tense feeling of the gums prior to menstrual flow, and increased gingival clavicular fluid rate, and salivary bacterial count is increased. In pregnancy, there is increased severity of pre-existing gingivitis from the third month onwards. Tooth mobility, pocket depth is present, GCF is increased, the prevalence rate is 50 to 100%. The clinical features are bleeding gums, bright red to bluish red gingiva, edematous gingiva, smooth, shiny, soft, raspberry-like appearance, tumor-like masses called as pregnancy tumors are seen. This is a representation of pregnancy tumor where you have a localized presentation and a marginal presentation. The microscopic features includes non-specific vascularizing proliferative inflammation. The epithelium, there is edema, reduced surface keratinization and accentuated retipex are present. In the connective tissue, you can see engorged capillaries are present and high levels of prevotella intermedia has been detected. Hormonal contraceptives, there is no influence on the gingival index or oral hygiene scores. Increased risk of periodontal destruction when taken for a period of more than 1.5 years is seen. Then in case of menopausal gingivostomatitis, it is also called as senile atrophic gingivitis, which is occurring in the post-menopausal period. It is characterized by a dryness, change in the color, bleeding of the mucosa and gingiva, dry burning sensation of the oral cavity, fissuring of the mucobuccal fold, extreme sensitivity to oral changes, there is abnormal taste sensation, salt, peppery, sour sensation, or atrophy of the spinous and basal layer of the epithelium is seen microscopically. The corticosteroid hormones has no effect on the gingival and periodontal disease. Hematological disorders, there is ecchymosis and petechiae into the soft palate area, abnormal bleeding from the gums which cannot be controlled. The above two signs are indicative of hemorrhagic disorders. They include leukemia, anemia and thrombocytopenia. Leukemia is divided into acute, subacute and chronic, myeloid and lymphoid. Chronic does not show much of clinical changes. A gingival biopsy may give the first indication of existence of chronic leukemia, that is to be correlated with the hematological picture. In acute leukemia, you can see blast cells are produced in large numbers. There is decrease in RBC platelets resulting in anemia and thrombocytopenia. Aleukemic leukemia is also present. In the periodontal and oral manifestations are leukemic gingival enlargement, hemorrhage from the gingiva, oral ulceration and infection. The gingiva is bluish red, cyanotic, interdental papillary enlargement is seen, and there is dense infiltration of leukemic cells in the reticular layer of the connective tissue, and there is intra and extracellular degradation. There is infiltration of leukemic cells into the periodontal ligament and also into the alveolar bone. So there is a localized necrosis. The oral ulcers are characterized by discrete punched out lesions covered by slough, including the buccal mucosa and the palate. Atypical herpetic lesions is also seen in patients the previous history of herpes infection. Anemia, pernicious anemia, it is an iron deficiency anemia. Tongue changes are seen. In sickle cell anemia, there is generalized osteoporosis, pallor, yellowish discoloration of the mucosa. In thrombocytopenic purpura, there is a low platelet count, prolonged clot retraction, bleeding time is normal, reduced clotting time. Oral petechiae in buccal mucosa, palate and tonsil region is seen. The gingiva is soft and friable, severe bleeding with slight thirst provocation. Immunodeficiency disorders is characterized by primary or secondary, which can be due to drugs or any pathology. Agranulocytosis is because of drug idiosyncrasy and cyclic neutropenia. There is absence of notable inflammation and hemorrhage in PDL and alveolar bone. Shiedekagashi syndrome, you can see rapid destructive periodontitis and mild bleeding, partial albinism and recurrent infections. Antibody deficiency includes A gamma globulinemia and AIDS. And cardiovascular disorders are atherosclerosis and hereditary defects. Metal intoxications includes bismuth intoxication, where there is GIT problems like vomiting, jaundice, oral gingivostomatitis, metallic taste and urticaria. Bluish black discoloration of the gingival margin is seen. Lead is characterized by peripheral neuritis and encephalitis. Increased salivation, coated tongue, Burtonian line and sweetish taste is seen. Benzene, there is ulceration, necrosis of the gingiva and alveolar bone. Psychosomatic disorders are habits such as causing injury to the periodontium, that is because of the effect of nervous system on the periodontium. Oral manifestations include grinding of the teeth, bruxism, generalized attrition wear facets, excessive use of tobacco, pan and betel nut. There is a direct correlation shown in anag. Thank you for the patient hearing. இதை அப்லோட் பண்ணிடலாம்.